Hello, I'm Shaheer Akhtar, resident Neurosurgery Leading Hospital, Peshawar, Pakistan. The title of this presentation is based on a report of 4 cases of neglected, malunited type 2 odontoid fractures that were treated with anterior retropharyngeal release with posterior C1, C2 instrumented fusion. The fractures of C2 comprise 9 to 20% of all cervical spine fractures, with type 2 fracture as the most common form. Surgical management is usually done in the acute setting. If delayed or neglected, it could lead to non-union or malunion, the fixation of odontoid in an abnormal position. Delayed cases usually present with progressive myelopathy and neck pain. Odontoidectomy or odontoid release through transoral route with posterior C1, C2 instrumented fusion is usually employed to treat such patients. We operated on 4 cases, age ranging between 33 to 60 years. All had a history of remote trauma ranging from 3 months back to 15 years back. The most common presenting symptom was neck pain, and all had progressive myelopathy. Radiology showed irreducible atlantoaxial dislocation. These are the preoperative images of 2 of these patients showing irreducible atlantoaxial dislocation and fixed anterior listhesis of odontoid process on C2. The patient was placed in a supine position. Traction under anesthesia was applied to check for reduction, which failed in all these 4 cases. Horizontal incision was given at the level of thyroid cartilage, medial to sternocleidomastoid muscle. Cervical fascia was divided and a plane was produced reaching the prevertebral fascia. Prevertebral fascia was dissected with a low power monopolar cautery. A gloved finger was slipped over the prevertebral fascia to palpate the depression between the fractured odontoid and C2 vertebral body. The position was also confirmed with lateral image. The bony and fibrous union was broken down in a controlled manner with a 3 mm chisel under radiologic guidance. The upper C2 vertebral body and the lower end of the odontoid were curated to prepare for fusion. Direct pressure over the C1 tubercle was applied at this point with cranial traction to check for reduction, but it failed in all these 4 cases. The wound was closed in reverse order and the patient was shifted to prone position. Standard posterior midline incision was made to expose C1, C2. The C1, C2 facet joints were curated to release adhesions. After achieving adequate reduction, C1 and C2 were fixed with C1 lateral mass and C2 pedicle screws construct. Bone grafts were taken from C2 spinous process or occiput if needed, and they were placed for fusion. A standard closure was performed. In all cases, adequate decompression and alignment was achieved. A minimum follow-up of 6 months is completed up to this point. Adequate fusion and decompression is achieved and maintained in all the patients, and all patients remain symptom-free up to this point. The conclusions are that anterior retropharyngeal release with posterior C1, C2 instrumented fusion is less invasive and avoids the risk associated with transoral approach as compared to the other standard options. It also allows the alternative of placing an odontoid screw in select patient who achieve adequate reduction following anterior release using the same approach.